Good afternoon, ladies and gentlemen. Thank you, Professor Natasha, inviting me here. I would like to share with you what are the mechanisms of angle culture. Do we consider all of them in the clinical practice? My name is S.Zhang, came from Zhongshan Ophthalmic Center, the biggest one and ranking #1 eye center in China. I don't have financial disclosure. As you all know, glaucoma can be separated two main types. Primary open-angle glaucoma, PACG, primary angle closure glaucoma, PACG. The picture shows you very well. When we talk about glaucoma pathogenesis, actually, there are so many questions need us to explore. Why glaucoma happen? Why IOP increase? Why acute attack happen? What contributed to angle closure? Then IOP increase. Besides traditional risk factor, a shallow anterior chamber, short axial length, small corneal diameter and reaches of curvature, secant length, and an anterior length iris diagram, there are newly found potential risk factors for PACG, including anatomical factor and dynamic factor, such as iris, choroid, and ciliary body. And based on ASOCT study, people have been found anterior chamber width, anterior chamber area, anterior chamber volume, iris thickness area and curvature, iris changes in volume with dilation, and lens wall are all risk factors for PACG. In recent years, people also found 3 more perimeter risk factors: relative lens wall, rectus insertion, and anterior choroid. This is rectus insertion, and this is anterior choroid. The last 2 was confirmed by my team. How about choroidal expansion theory? This hypothesis has been raised by Dr. Prickly for many years. But until now, the choroidal expansion theory has not been confirmed in any imaging technology until EDI and ESSOCT comes out. My team has been engaged for this project for several years. This picture shows the choroidal expansion and cause the pressure go onto the anterior chamber and block the anterior chamber to cause the IOP increase. And this picture was drawn by my daughter. So we performed the posterior choroid in PACG and published a series of the paper. And also we have been performed iris and choroid and many people too. And also iris ciliary body and choroid, and also found anterior choroid also play a role in PACG too. However, all of the above study was cross-section studies. We still don't know the cause-effect relationship between choroidal expansion and anterior segment change. Then we perform an upside-down position to study the change of biometric perimeters in anterior and posterior segments. And we found out when kept in upside-down position for 1 minute, they will obviously increase choroidal thickness, and then elevation IOP, and then decrease anterior chamber depth. And also, the MFAS image also shows the increase of choroidal thickness may be due to the reduced choroidal blood flow. So these studies strongly indicated in upside-down position, there was choroidal thickening, anterior chamber shallowing, and IOP elevation with reduced choroidal blood flow. And choroidal expansion and shallowing of the anterior chamber may be of relevance for the pathogenesis of angle closure. All of the above study came up 28 paper to support one hypothesis that choroidal expansion or thickening may act as a mechanism for angle closure. And this symmetric picture shows you the process like this. However, single series could not always answer a big question: who triggered the acute angle closure? Based on the late literature review and our studies, the acute attack may be mediated by smaller ocular dimension plus a thicker choroid at baseline, in addition to an abnormal behavior of uvea with a normal anterior and posterior segment. Autonomic nervous system, including sympathetic and parasympathetic pathway, may warn iris pupillary block or choroid expansion, engorgement under some certain situation like stress, insomnia, and emotional change, and cause acute attack. Of course, this is just a guess by myself. In clinical practice, acute angle closure mainly results from iris bombay, we call pupillary block. And the corneal edema is the main sign when acute attack happens. Even to this extremity situation, stromal corneal edema and falls in decimal membrane. And this is the outlook of resolved acute attack. On the other hand, corneal angle closure is a progressive disease with a normal appearance but shallow peripheral anterior chamber. Under the gonioscopy, you can see narrow angle, peripheral anterior significant with different degrees. The corneal angle closure mainly results from non-pupillary block. Under the gonioscopy, you can see not obviously iris bombay, peripheral iris heaping. Under the UBN, you can see a thicker peripheral iris or anteriorly positioned or rotated ciliary body or plateau iris configuration. Or it can result from the mixed mechanism, which combine two or two more situations, such as the iris bombay plus plateau iris configuration, iris bombay plus a thicker peripheral iris, or iris bombay plus the anteriorly rotated ciliary body. This is schematic diagram drawn by myself. It's a beautiful picture, right? It's a plateau iris configuration under UBN. A flat central iris plane, iridotrabecular contact, loss of the ciliary sulcus, and anteriorly positioned or orientated ciliary process that critically narrow the anterior chamber recess by pushing the peripheral iris forward. Actually, plateau iris configuration, we can get two types. One is just I mentioned, the classic plateau iris, and another one is Asian plateau iris. This is different. Here is because the thicker peripheral iris and the iridociliary sulcus is open. Based on their mechanism, the surgical option for primary angle closure included LPI to relieve the iris bombay. Another one is phaco. You can see after the phaco, the anterior chamber volume, the space enlarged than the before. Also, we can do the trabeculectomy, and this is a future breath. And also, we can do the combined surgery, all kinds of combined surgery, combined trabeculectomy, express tube, cyclophotocoagulation, all mixed. However, you can see some pivotal studies raise some questions. One, studies called EAGLE, to study the early lens ejection for the treatment of primary angle closure. This is a randomized controlled trial. The treatment group is clear lens ejection. The control group is LPI for the focus on the PAC and the early stage of PACG. And 36 months later, they find out clear lens ejection group can get better IOP and quality of life score. Also, they find out clear lens injection group can save more money. Another study is called ZAP studies, look at the LPI for the prevention of angle closure. This is a single center RCT, LPI for one group, follow-up for another group, focus on PACS, and 32 months later, they find out incidence of primary outcome in LPI group was lower, and incidence of the primary outcome in LPI group was very low in community population too. So they conclude widespread LPI is not recommended. So two papers raised the question to challenge the traditional preferred treatment for PACG, the LPI, trabeculectomy, or combined surgery. However, in my eyes, the controversy could always drive the development of academic research. So let me conclude my talk. Combination of anterior and posterior OCT imaging. We got the whole structure information of anterior and posterior segment, and some perimeters change will contribute to PACG, especially the dynamic change of iris, choroid, and volume perimeters. Increased choroid is a risk factor for PACG incidence. There is an association between choroid expansion and shallowing of anterior chamber. PACG is complex disease, which might be mediated by smaller ocular dimension, plus a thicker choroid at baseline, in addition to abnormal behavior of the uvea. LPI combined with straws or trabeculectomy remain traditional preferred treatment for PACG. Clear lens injection and LPI, which is better in the long-term follow-up, is worth further discussing. Whether the law recommend widespread LPI in PACS meet the clinical practice or not is still controversy. I would like to thank you, my Glaucoma Imaging Corporation Research Group, Professor Ting Ang from Singapore, Chris Liang from Hong Kong, Shanling from the United States, and Makoto from Japan. This is my team. You can see all the boys around me, right? And this 3 book is my published book, Illustrated Clinical Diagnosis and Treatment of Glaucoma, in the surgical technique and fields of glaucoma, and the anterior segment imaging, the examination and diagnosis of glaucoma. In this book, you can watch 145 online surgical video by myself from the website, from the bottom of the book. And this book, all of these pictures, 25 pictures, answer 250 clinical questions. And this is a new one. It's all of the picture to talk about gonioscopy, UVN, ASOCT. The last 2 I would mail to Professor Natalia, but the post office was rejected because of the COVID-19. I hope I can find another chance to mail you again. Thank you very much.